Test. Hopefully you've rested enough.
For our last day of wonderful presentations and lectures. I'm really honored to invite to the panel Professor Lutz Nielich and Professor Milan Macek to start this session. Please.
Yeah, I think good morning. After the party, I think is before the lessons here, I think, and the discussions. It was a wonderful experience last evening, I think, very lively. Milan, you missed something? Yeah, okay. I think we heard yesterday a lot of therapeutic aspects, new challenges, I think, modulators and everything. But I think very essential is that the diagnosis for the patient is correct, is done appropriately and as early as possible, and I think that there are no doubts, I think. I know a lot of patients, I think, who really are unsure if it's really CF, and they want to reassure over time, so several tests are repeated, and I think the precision of the tests is very important so that you can really tell the patients it's CF, and the story of the best therapy and the best approach can start. I think one in the guidelines, I think it's a very important task. Over the last 20 years, I think all the updated guidelines, the sweat test is the central start of the diagnosis. Also a gold standard of the diagnosis because this is available, can be done, can be shared the experience immediately, and I think it's a test which has a lower cost than the genotyping, and I think this is very important. It's available, I think, in many places. The clinical presentation of cystic fibrosis, we will hear about that in the next talk, are very variable, I think. And now we heard about newborn screening, we heard about family history, I think, but the signs and symptoms, and Irina will talk about that, I think, is very wide, and you have to offer a sweat test often to get to that. And the sweat test has two important roles, and I think this is very important. If you do it properly, you have a sweat chloride measurement above 60 millimole on 2 independent occasions, then it's straightforward to the diagnosis of cystic fibrosis. The genotyping will help you to confirm to a certain extent, but also guide you through treatment and family planning, so it's a very important task. But on the other side, and this is very important with newborn screening, if you do it properly and it's below 29 millimole per liter chloride, you can also make CF unlikely. You could not exclude cystic fibrosis because there are some rare situations, I think, but I think this is very important also for newborn screening and for parents to make it unlikely, but you have to recover if there are new symptoms and other things. And then we have the gray zone of the 30 to 59 millimole per liter, which is rare, but more often occurring in adults, I think, because 20% of the adults have a slightly higher sweat chloride in this gray zone. And if you work with adults for the diagnostic purpose, this is often a challenge. And the genotyping comes into place. And then the question, I think Milan will talk about that, what is really a causing mutation? What variant cause cystic fibrosis? This is a very challenging question in this time. And then last but not least, physiological tests can occur, but I think this is not established in every country. And in Germany, I think there are many centers, but I know other countries like Spain or Portugal, and even I think in Ireland and in Scandinavia, there are no further test centers anymore. So I think the main goal is here, sweat chloride is a first step, and it's a very important step, I think, on the journey to the diagnostic, or to make CF unlikely and to look for other diagnoses as reasons. The sweat test is a very complex procedure, we have to say. It sounds easy, but I think it has been established more than 60 years ago by Gibson Cook. And I think this was a revolution because it was known that the sweat of cystic fibrosis patients has a higher elevated electrolyte content. That was clinical experience in heat waves and so on, that the patients lose sweat. And then the question comes, how can you investigate the sweat? And the Gibson Cook was one of the first, I think, who bring it to a local sweat stimulation with pilocarpine, with a beta-adrenergic. And I think that's very important, I think, to stimulate locally, collect the tests, sample the sweat, and then analyze the sweat. And it takes quite, I think, 10 years to commercialize it in a system which is easily accessible. You can buy it, you can buy supplies, it's standardized, so the quality is more standardized, and that was from Vescor, former Vescor, now it's Elitech, now it's Bruker, so you see it's a long generation. And you have this stimulation here, you see it in the, I think that does not work very well. You see it in the middle, I think. That's a stimulation of a baby, I think. You have a power battery, I think, and then you have GLDIS, where the pilocarpine is on the skin, and it's by the voltage and accuracy, it's going to the skin and stimulated locally, and then you can sample it with a capillary system, not with a gas system, and then you have pure sweat, I think, and this can be analyzed, I think, via conductivity with a sweat check or with a Claude meter, I think, which is a more labor-intensive. Now it has been updated to also Macroduct Advanced, same system, but different size, and has also in the display the whole information about the tests, which is an additional benefit, but it's the same principle. It's nothing new, and the old one is just, I think, fits very well. And then for newborns, I think the nanoduct has been developed in the past, which stimulate and measure immediately, I think, also on the skin, the conductivity. But regulations play an important role, and medical devices have been regulated by the EU laws. And we are not in the EU here, I think, but we have to say that this is a huge market, and the company always want to focus where they invest money. And though they decided not to continue delivering supplies for the Macroduct, and the sweat check was out of the market. So we have only the Macroduct, and the nanoduct was taken from the market. So we have only the Macroduct Advanced and the Claude check as diagnostic commercial available tests in the European Union. And the company will adapt the strategy worldwide over the next years. So running out of the supply for the stimulation, I think the sweat check for the round one, I think will come in the next year. So we are working from the ECS FPR side to support centers in the low and middle income countries to move to the new system, to be ready for this moment where it's hard to get the test. There was a survey, and I think it shows, I think, that the interest, I think, in 2018, there is a huge variance approach in an interpretation of results, and many centers are not using the agreed cutoff levels. That is really, I think, very important, that over the 60 years, a lot of local habits have been developed, which really, I think, affect the accuracy of the test. And there's a variance with respect to collect sweat from two sides, that means both arms, which is more, and we have always the high pressure on the cost, because a sweat test nowadays costs around 40 euro in only the materials, and then the lab is coming in. So this is quite an affordable, but I think once alive, I think it's quite good. The cost for sweat testing are lower than genotyping, but I think genotyping has also dropped dramatically. That a proper sweat test makes a difference, I think, is an old story, and I would like to highlight this, that even Schwachmann, I think, 1997 said, we have referrals with a positive sweat test, but we could not confirm it with our accurate method. So I think the sweat test should be always, if the patient behaves differently, should be checked, I think. Never trust it if it comes from another one, and if you're not quite sure it's done properly. False negative result, and this comes from Chapel Hill, the Pope of the sweat test, Vicky Legree. She reported in 1998, I think, 147 CF patients, and in 12% it was false negative sweat test in the beginning and a diagnostic delay, because then they seem it's unlikely and they didn't thought about it. So I think do it properly, and I think you can avoid that. And in Germany, in the German registry, there are also 51 patients where the diagnosis has been done not properly and has been revised afterwards with critical review. We have this stimulation, I think. We have different guidelines, I think. One of the latest is from the ECSF, I think a very important one. I recommend it very much. You have the pilocarpine iontophoresis, you have the Gibson-Cook or the Westcore macroduct system. You have a collection time of 30 minutes, which is important because I think this stimulates physiologically best, I think. And after the 30 minutes, there is no fluid secretion anymore, so you will not get any more volume, I think. And very important is to have the minimum of sweat fluid, I think, because sometimes you need for the measurement a volume which is higher than the physiological minimum volume you need to have a proper stimulation. For the macroduct system, it's 50 microliter, and for the filter paper, it's 75 microliter. If you analyze a sweat, I think in your lab, sometimes they told you I need 50 or 100 microliter, and the probe is not enough. But from a test, I think that is. So you need to choose, I think, a chloride analyzer which is giving you the results within this minimum volume. And the chloride meter has 20 microliter minimum, and the conductivity measurement, the sweat test, is even lower, but some labs have higher minimum volume they need for the analytics. It's very important that we have, I think, different reference values, I think, for the interpretation, and the conductivity is, I think, a sort of a transfer of current over a fluid, so it's not chloride measurement, it's an equivalent, so it's a construction, and corresponding to a volume, I think, which has this electrolyte content. So we have the 60 millimole of the sweat chloride corresponds to more than 80 in the conductivity, but individually there are differences. So I think there's always a recommendation to confirm a conductivity by genotyping or by chloride measurement, but I think it's very robust, I think, but individually there are differences and more than 20 differences. Are there reasons to think about the results and the interpretation? I think it's very important that the sweat chloride is a very sensitive and specific test. Over 95% of the patients have a sweat chloride over 60 at diagnosis, and is high specific. No impact has fasting, antibiotics, diuretics, IV lines, but the false positive can come from evaporation, so a concentration of the electrolytes in the sample, from severe malnutrition, I think that's well known. Anorexia nervosa has higher, and if you correct the malnutrition, it's going down. You have also some medications, very rare, but you have rare other conditions, and if you think about them and you correct them, normally the sweat test goes down. One of them is also thyroid problems. False negative ones could be done if you have edema, I think, if you are dehydrated, and if you have a dilution of the sweat samples or low sweat rate. So I think this is important to know. It's rarely a problem. You can think about that, but you have to think. We have also some mutations, I think, where the sweat chloride is below 60, but this is a really rare one. So I think normally, I think you should not think about that too much. The sweat test in time of newborn screening. And newborn screening is totally different because in the times I started with CF care, I think the patient looks like CF and you confirm it by the sweat test. So that's a little bit more easy, I think. But with the newborns, I think you have healthy newborns, I think, and you are making a diagnosis based on values you see on a screen. I think that makes a huge difference. And also for the parents are not trusting in the 31 or 29 or 61 or 30. They look at their babies, and you have to be pretty sure that you can convince also that this healthy baby has CF, looking healthy, but has CF. So it's a changing dogma from clinical confirmation, clinical CF, to a functional measurement which is indicator of CF in healthy babies, I think, or healthy-looking babies. You can do it as early as possible. I think very important is that you take the quality into account. It's a lifelong diagnosis. Meconium ileus can get a false negative sweat test, newborn screening, so these patients have to go for a sweat test at all, always, and to be precise as possible, and we will here talk about CF spits, the problem of newborn screening if you are not sure after the confirmation diagnosis. Very important is a quantity not sufficient. So if you make a test, not every test should be analyzed. It should have a minimal volume of sweat, I think, from 50 micromole. And in this test, I think, for macroduct, you have this capillary system. And here you see, you can indirectly read, I think, where the 50 microliter are. And then you can analyze it or you can weigh it. You have to monitoring that, and you should not analyze that tests with lower volume, I think. And you have to have also experienced people, mostly the nurses or the lab persons, who have to be critical if they have an unacceptable high quantity, not sufficient weight. I think there are some reasons that the sweat test fail, I think, if the baby is too low weight. Below 3.5, I think the risk is much higher not to get sweat quantity. The postmenstrual, if they are early birth, if they are postmenstrual week below 35 weeks, and try as early as possible. In the first day, it's not possible because the sweat is physiologically much higher and it goes down, let's say from day 5 or 10. You can do it immediately, I think. You have not to wait. First try on one side, and if you don't get in, just try it on the other side, I think. That's a good approach in contrast to the bilateral testing, which is recommended in the US. And if not successful, repeat the sweat test, but do a fecal elastase immediately, I think, to really catch up with the patients who are pancreatic insufficient and that they can be treated immediately and repeat the sweat test after. In conclusion, I think it's a diagnostic gold standard. Quality matters, I think. I hope I convince you. And take it seriously. It's a lifelong diagnosis, and the sweat test for exclusion of the diagnosis or making it unlikely, it's very important as well. And do not mix up conductivity with chloride. There is a difference of 20 in the guidelines. And it's extremely important, I think, critical step in newborn screening. So it's getting much more as a gold standard for the patients where you say sent home with making CF unlikely, I think. And the sweat test for the modulator use is often a secondary point. I think it corresponds not closely with the clinical response, but in general, you see some up and downs. Individual changes could help to interpret compliance or medical non-responders. So the sweat test has a different role in these patients, but I think the diagnostic is, I think, a very important tool. Thank you.
Thank you, Lutz, very much. So questions to Lutz? We still have some time.
No question? Okay.
No, all clear? Okay, then. All right, so now I would like to invite the second speaker, which is Irena Kashmi from Albania, and she will talk about the early CF diagnosis, which is a way of prognosis improvement, and what are the indications for sweat testing, so complementing what Lutz was speaking about. Thank you, Irena.
Thank you very much. Excuse me. Mirëmëngjes të gjithëve.
Good morning to all.
I pushuar mbasi mbrëmje shumë të këndshme që
You have rested after a very nice evening organized last night.
Profesor Lutz sigurisht që nuk është e lehtë.
Speaking after Professor Lutz, it's not an easy, but I would like to start this presentation with motivation sentence, but a sentence which is supported truly in a new recent scientific data setting early diagnosis of CF for sure that improves the future of patients with CF and opens a door in regard to the new approach with modulators. In the context of importance, the sweet test it has in setting early setting of this diagnosis, surely you had a very interesting and convincing presentation. Of course, this is a standard test of stipulating a diagnosis, which fortunately is available even from the countries under development. And I will speak furthermore for the forms of sweet test. These developing countries are having that gold standard of setting a diagnosis, supplemented and being supported, of course, by genetic diagnosis. But in cases, even though we do think it has been exaggerated, all the screening of CFTR, quite often it gets an extraordinary value in cases mutations encountered in this testing are of unclear clinical consequence, or when to encountered mutation might be in a chest position, or in minor cases should be, but it's not that this doesn't happen in a daily practice when we have not good processing of genetic sample. A sweet test, which measures respectively, is based on chloride value on sweat, is a test which, simple test. We are using it, in fact, in two first milestones. It's similar to conductivity test, but the measurement afterwards changes the device measurement, where the principle of measuring chloride redometer is different principle, whereas in meantime the conductivity test principle, it's another principle. But two first milestones, as described by Professor Lutz, are respectively provocation of cholinergic of simulation of sweat through endophorese. Second milestone by collecting sample of sweat according to clear criteria to have a good sample, processing sample of sweat test mentioned in the previous referral. Afterwards, by using of macroduct system of Westcott type, which requires at least 15 microliters of sweat collected, then the measurement not only of chloride ion in sweat. Where are the indications for the sweat test? The sweat test is indicated respectively in all cases when national program of neonatal screening is provided to the population of a respective country, and for all these cases that results with high levels of immunotrypsin, reactive trypsinogen, or in genetic testing cases of collected samples in the first days of life, resulting with indicative mutations for the disease. But for the cases and countries which doesn't have inclusion of the neonatal screening, every individual who has suggestive data for CF disease, respiratory disorders, non-adding weight, gastrointestinal disorders, or other problems making you suspicion on that are contingent influencing using the sweat test, and surely as a blink of family of affected families from the CF. In the recent years, by beginning of modulatory treatment, another contingent of patients who benefits through biomarkers measurement for clinical assessment about the clinical response on modulators, it looks like a sweet test is completing this mission. At this point, I have represented respectively the assessment of sweat test. So the assessing the sweat test mentioned by Professor Lutz, value of chloride in the sweat over 60 mmol makes diagnosis of CF possible and clear, and a value under 28 mmol not indispensably exclude 100%, but in most part of that excludes the disease. And the contingent, which really is interesting, which fortunately doesn't comprise a high percentage of individuals and cases we encounter in a daily practice, but are possible to be encountered are respectively intermediary values, which by all means beyond this requires further examinations for confirmation or exclusion of the diagnosis. Professor Lutz already mentioned best criteria and strict performance of procedure in order to have a acceptable and positive result and undisputable result of a sweat test. Of course, there are criteria related to the patient. Commencing from the newborn should be over 2 kilos, over 36 weeks of gestational age. It should be processed as soon as possible within first 10 days of life, and ideally within the first month of neonatal period, the first month of the life, and possibly should be performed and analyzed and reported within a short time, because as Professor Lutz mentioned, when you say to a parent that we have a suspicion in a diagnosis, possible diagnosis of CF, surely we have to exaggerate that within a few hours, the response indeed in regard to the patient. But how the situation is in the countries with restricted sources, a country like, for example, Albania is part of that, of course. Sweat test has extraordinary role in these countries in order to set diagnosis in all suspicion cases, especially in the countries where neonatal screening programs are not yet set as a national programs. We are part of that as well, Albania. Its effective cost, it's not invasive, is absolutely a proper approach to an early diagnosis of cystic fibrosis, and might be found in these countries as in sweat chloride test form, as well conductivity tests. In this slide, I have presented priorities of one towards other, advantages of the one towards other. Of course, I want continue to repeat and says that sweat chloride test is a gold standard for setting a diagnosis. It's a more accurate, more precise, respectively based on measurement of chloride electrolyte, but has a minus, which I think it's not important minus. It's that it's more time consuming. In meantime, sweat conductivity test, which is based on electrical conductivity that collected sweat has based on electrolytes, respectively, natrium and chlor, but scientifically confirmed that, in fact, respectively to the content of chloride, this conductivity is an acceptable test, likable, it's user in and simplified in using, and which remains in the minus, which might remain only in the context of screening. So having screening capabilities has discrimination skills compared to discrimination skills of patients. Of course, in regard to CF patients, through a test with the positive conductivity, it always should be performed the diagnosis of the diagnosis should be set through second test of chlorometric type or a genetic test. More or less, these are the values Dr. Lutz mentioned, so I'm trying to skip this in order not to repeat the items. So how the situation in Albania is, we have in this result, we always performed test sweat chloride test of type conductivity type. It is a simple test, a test which we try to perform in a best correct way in order to have accurate results as much as possible. But in the other hand, at the time we have a positive sweat test, the only way to confirm the diagnosis is to make another test, same of conductivity type, to avoid any possible mistake about the first test, and afterwards followed by genotyping. In our country, considering very few resources. We have access only in a small panel of 11 mutations encountered within Albanian population snapshot panel, which in most of the cases identifies mutations, confirmed mutations of diagnosis, but we have specific cases also which have only a mutation and they don't have another mutation, and that is why afterwards we are forced to make a wider genotyping, what arises the need to have a larger panel except regional variants we have in disposal. Who would improve, how to say, early setting of diagnosis in Albania? Of course, recommendations we do receive from European Association of Cystic Fibrosis that quite often we do give to ourselves. It's respectively implementing neonatal screening, improvement and awareness of healthcare physicians and on disease, and of course enhancing genotyping range in order to set cystic fibrosis diagnosis. I am fully convinced that setting of early diagnosis of cystic fibrosis is critical and very important to improve the progress and the future of these patients. A sweat test of type chloride remains the most credible method. Albania might improve access in diagnostics as provide awareness to the population. Of course, the time is the best treatments, gives us an opportunity for a better quality life and open a door for advanced therapies. Thank you very much.
Yeah, thank you very much for this overview. Any questions from the audience? I think one question I have is, which patient do you investigate by a sweat test? Now, since 1 year, you have access also to a sweat conductivity measurement. Which patients are you testing? Is it gastrointestinal, pulmonology?
Okay, we test every patient that there is a CF patient. So with recurrent respiratory problems, failure to thrive, gastrointestinal problems like steatorrhea, and they are in Albania having the percentage of delta F 508 at level 85%. It's clear that there are the most classic clinic presentations, so it's not very difficult to diagnose them. For us, it's a challenge. The diagnosis in later ages, I mean toddlers or adolescents with very rare mutations. We have got 2 patients, and I would like to benefit from this occasion to thanks Professor Macek helping us to genotype all the patients. There were only 1 mutation detected, but the other one not, because of this limited panel for mutations. So it's not very difficult for the classic to doubt, but of course it's difficult and a challenge for the very special and very tricky cases with their mutation.
And how much tests do you perform per year? And how much diagnosis do you get
we perform at least 50 tests per year, but we are a bit restricted because of the availability of the test, because I think that every patient without major symptoms, even minor symptoms, should be tested. So if we have more tests, I'm sure that we'll perform more than that and should perform more than that. Thank you.
So any questions from the audience? No? Thank you very much. Then it's a great pleasure to introduce Milan Maciek, a genetist from Prague University, but I think he's also well known because he has also worked on the epidemiologic aspects of genetic in Europe and especially in Eastern Europe. And as Ina mentioned, I think there's also a support project you will mention as well, I guess, to get more out of this collaboration.
Thank you, Lutz, but mainly thanks to the organizers to be able to speak in front of you, and apologies I couldn't be here with you for the last 2 days because there was a concurrent genetics meeting in Prague which I had to chair as a society chairman. I would like to now briefly touch upon another biomarker in cystic fibrosis, which in fact are the mutations in the cystic fibrosis or CFTR gene. And what is the role for modern variant-specific okay, so modern variant-specific therapies. Just quickly, statement. So, very, very briefly, as you all know, cystic fibrosis is a recessive syndrome. I say specifically syndrome because I'm in genetics. Cystic fibrosis is no different from all other genetic syndromes. And by syndrome, I mean that it's a multisystemic disorder, which means affects many organ systems. And also, there's a continuum based on the severity of molecular pathogenesis, which is then reflected in the severity of the symptoms. And the most important thing is that since it's a recessive disease, I mean, the less severe mutation is the one which determines the cause. So if you also, for eligibility for variant-specific therapies, if you have a residual function mutation, it means that it can be modulated and cystic fibrosis can be efficiently treated. Now, there's a lot of mutations in the gene. I mean, it's almost notoriously known that there's a so-called cystic fibrosis CFTR1 database, which was established already in 1989. And this database is still very helpful, although nowadays there are much more genomic databases located in Europe and in the US. So it's not as actual as it should be, but it's still a very important resource. But the thing is that it's only a so-called variant local specific database, which means that there are only mutations listed there and very, very brief unstructured comments as to what is the associated phenotype. So it's useful, but not that much, as I will show you later on. Now, in terms of the distribution in European derived populations, we have a very good overview. This is all published, and thanks to Lutz and the ECFSPR, the patient registry team, we know which are the most common mutations in the cystic fibrosis gene. So, for instance, the dominant mutation F508del is very common in Denmark, but we also have seen that it's quite common in Albania. As Professor Kashmi said, the reasons for this could be twofold, either population specificity or a bias towards more severe cases of cystic fibrosis being clinically diagnosed. Then you have this Mediterranean allele G542X, then N1303K, and all the way down. So this is the list, and it's all in the public domain. Now, the thing is that if you look on the 2023 report, the distribution is different. Now, if you look on, for instance, Albania here on the top, the Delta F508 mutation is the most common one, and there's a small part of those which are not detected so far. And I have to say to Professor Kashmi, it's not about broadening the panel, it's about sequencing, because you don't know what you're looking for, and if you look for, use panels which are optimized for Western European populations, it's a waste of money and waste of time, because very likely you will not miss these specific private alleles. Even more so, for instance, Armenia, most of them are non-European. The point I want to make, and here we are in Southeastern Europe or in the Western Balkans, the more you go into the south of Europe, the more heterogeneous the mutation composition is, and the more important it is to sequence. And if you go outside of Europe without sequencing, you just cannot establish the second biomarker in cystic fibrosis, which is the presence of an allele. The other thing which is very important is that in all rare diseases, or majority of rare diseases, for these variant-specific therapies using orphan medicinal products, or orphan. And for instance, the ETI therapy is nothing else than a triple combination of 3 orphan medicinal devices. You need to have a biomarker onto which you anchor or onto which you base the eligibility for variant-specific therapies. So again, this is from the ECFS patient registry. You have 2 extremes that, for instance, these various combinations. So here down, I'm sorry, it just doesn't show the pointer, but bear with me. The red square essentially is ivacaftor. The orange one is Luma and ivacaftor. Then the pink or violet, depends how you see it, is tezacaftor, ivacaftor, and ETI, the most common one, is nowadays ETI, Alexa, Teza, and ivacaftor. And you can see that in various countries, there's various forms of eligibility. Still, ivacaftor is quite important, but dominantly in children and adults, it's the ETI therapy. But sometimes, like in Latvia or in Hungary, you see that the lumacaftor, ivacaftor is dominant. But this is not because of the mutation. This is because of this, I can say that openly, rather nasty, I would say, corporate policy as to what drug combination is reimbursed in that or other country. And here we try to help as much as we can, like in the case of Latvia or in the case of Hungary. So mutations are important, but also the, I would say, reimbursement status is important. But without mutations, you don't get reimbursement. It's simple as this, and cystic fibrosis is not different from other rare diseases, which we are treating at our national center. Now, what are the common pathogenic variants worldwide? This is just for the information. We still don't know much about Southeastern Asia. Central Asia, we will be there with Lutz in 2 weeks' time to sort this out, because WHO Europe region spans, in fact, from Portugal to the Pamir. Now, the other thing which we need to bear in mind, that some of the mutations or some of the cases where you don't find mutations using standard kits are due to a much more complex pathogenesis in cystic fibrosis. It's not only those point mutations or small insertion deletions such as the F508del mutations, and there's also large intragenic deletions. And for instance, the deletion 2-3 is a very common one in Slavic populations east of the Elbe River because of historical migrations. While, for instance, in the Middle East, you have the deletion 78 to 18 or 22 to 23, and they are usually associated with severe cause of the disease. And here we suspect, because of the Ottoman rule for several hundred years, that a lot of these Middle Eastern alleles could be here due to admixture. There are also large intragenic deletions, which then explain the so-called missing heritability. Now, one thing which we need to bear in mind, especially in Western Balkans, are population isolates. There still could be some in Albania. Definitely there are some in Montenegro, in Serbia. And for instance, a nice example is the Transcaucasian region in Russia, where even tribes have their own specific mutations because of the inbreeding. I say that sometimes if you find a family with rare mutations, you look around and you realize that the whole family, even without knowing, is related through generations and generations to come. And by the way, who of us knows what the grandparents were coming from, where they live, who were their kids, and so on. So again, there's a lot of things. The other thing which is changing, and very, very quickly, are the demographics in Europe. Here, if you look on, for instance, here on the southwestern Balkans, so for instance, in Croatia, the most important minority are the Bosnians. Vice versa, the Croatians are in Bosnia and Herzegovina. Bosnians are also obviously common in the space of the former Yugoslavia. The same for Kosovo, Albania and Kosovo. The relatedness is quite obvious. But also, for instance, Moldova in Romania and so on. So when you look at your patients and when you send them for genetic testing, the very important piece which helps us a lot is to ask them, although sometimes we have these, I would say, very unpractical, to put it politely and diplomatically, regulations that you should not ask ethnicity and these things like that, non-discrimination. But in genetics, without ethnicity, it's very difficult to find out what's going on. So please don't hesitate to come. And the same, also knowing the situation in the Western Balkans helps our friends in Scandinavia, because a lot of the Scandinavian immigration, and we discuss it with our Swedish, Norwegian, and Danish colleagues, is coming from Western Balkans, is coming also from Kosovo. So knowing the situation here will also help our friends in Scandinavia. So I just want to say how all these population migrations isolate are interrelated, and that genotyping helps. Not to speak about Ukraine, but this is a specific thing. So delayed diagnosis in rare and ultra-rare disorders is a major issue. And I would say this is the position statement of the overarching patient association in Europe, Eurordis. And the motto is leaving no one behind. For cystic fibrosis, leaving no one behind for this region is the key to assure that there's equitable diagnosis all over the place, for all the ethnicities and for all the patients. Lutz spoke about sweat chloride, we speak about genetics. So it's not about the rarity, CF is quite rare here, but it's about the lack of resources. And as you know, Europe is very heterogeneous in terms of resources for healthcare. And the way how the healthcare, I would say, approaches marginalized populations, rare diseases, and cystic fibrosis is a prime example, is the way how to decrease these disparities. So, coming to the practical bits, we have been running this Vertex projects, which I spoke about many times before, and altogether we have been tested thus far over 2,000 cases from 26 countries, which is almost 4% of the ECFS registry data, and 2% worldwide, which is amazing. We did it in 2 people. I'm not boasting, but it's amazing how the operation was successful. Papers are slowly coming out, and as you know, how the publication policy is ongoing. The project stopped, but we were able, because of the success, to get to have some special, I would say, financial deals with our contributors, to whom, I mean, distributors of sequencing chemistry and kits and assays and so on. And they were so excited by this fact that we were helping these under-resourced countries that in the end they gave us large batches of consumables and chemistry free of charge, because they felt it's right to do it. And they know that essentially for them it's also indirect PR. So we still have a lot of chemistry and sequencing kits and assays left, and we continue as we speak. So you can continue sending us cases as before. And once this money runs out, the hospital administration says, okay, and then we signed a deal with the ECFS, and we continue under the umbrella of CFS. So the genotyping is ongoing. And very, very briefly, it's an academic project. There are no strings attached. We do it because we want to do it. It's an extra work for us, but we love to do it because we think it helps. Unlike with the previous Vertex project, we are not anymore bound by US regulations. We expect full patients' names, full identifiers. We are a healthcare institution which is accredited. So there's no need to worry that the patient data will be leaked or whatever. We do it like any other test within the European Union legislation. And of course, we do sequencing of the entire CFTR gene. And then we hope to have joint authorships where the local people should be first, second, third, or whatever, and we are only somewhere in the back because it's for you, it's for them. It's for them to raise the awareness and to show CF is there, and they have eligible patients for CFTR modulators. The only condition we have that if we have a new mutation, which is not known, that this data set is pseudonymized and sent to CFTR2, because CFTR2 is a worldwide resource, and they will publish mutations which are, I guess, more than 3 or 4, something like that. So every single mutation which is added there, the unknown, adds to the, I would say, level of expertise which is worldwide. Lutz mentioned the sweat chloride. I have to say that sweat chloride is very important, and it's a key diagnostic gold standard. That's a cliche, but it's true. But for instance, we found out that in Africa and the Middle East, where you have difficulty to procure all the macroducts and so on, it's not that easy. It's also hot. The sweat evaporates and so on. Sometimes, working with experienced clinicians and doing genotyping of the entire gene, when you find 2 mutations, that means confirming the recessive genetics there, you can sort of leapfrog, that means jump over the gradual introduction of sweat testing, confirm it, and empower the local community that CF is there. It's not, luckily, it's no more the case as it was like 20 years ago in this region, but still sweat testing is complementary, but sometimes it helps because it's very simple. You just draw blood and you do it. So we do sequencing very, very briefly. The main point is we need 3 well-soaked Guthrie cards. And the reason why we use Guthrie cards is they're easy to ship because you just dry them out. You put them in an envelope, you send them or you take them with you. There are no regulatory problems, there are no infectious disease problems, and so on and so forth. And we developed this system based on our 2-decade-long neonatal screening scheme where we learned that Guthrie cards are fine. And of course, we do sequencing, look for the common deletions, and this thanks to Deviser, who gave us a lot of free assays, we are able now to continue without charging ECFS, which is great. Now, also large deletions are there, just very, very quickly. I would like to point to one fact. There's this complex allele, which means that you have 2 or more variants in the same gene. You know, in recessive conditions, you have 1 allele, 2nd allele, mom, dad. But in a complex allele, you have 1 major mutation, such as the F508 del, and very close to it, well, I would say, tired, I cannot calculate, 41 base pairs apart. There's another missense mutation, change of an amino acid, leucine to phenylalanine. And for some strange reasons, which is not completely characterized, and we work on it with Professor Isabelle Sermet, these people are non-responsive or partially responsive to variant-specific therapies. And this mutation is quite common in Slavic populations, this complex allele like Russia, Bulgaria. We now see it even in Turkey, in Romania, and so on. So it needs to be borne in mind that if you have a non-responsive patient, it could be due not to his or her non-adherence to therapy, but due to the unfavorable genetics. And of course, the more you look, the more you find. I don't want to go much into details. Now, with the expanding new technologies and with long-read sequencing, we see that there's not a single sort of clean, simple mutation here, mutation there situation, which is to be expected. And we are all riddled like corals with mutations. We have like in a coding sequence, you have 250,000 variants. Each of us has 250,000 variants in our coding region, but only, let's say, 4 or 5 are pathogenic. But even if those 4 or 5 are pathogenic, the remainder 2,499,999 are still sort of modifying the way we look, the way we metabolize drugs, which is, for instance, like the ETI therapy. So there are no surprises. This is just, in the end, very briefly, this is the situation in Albania, and we are really grateful to collaboration with Professor Kashmi and her colleagues. And in fact, with Albania, we started even in the 90s when the patients were sequenced in Tor Vergata in Rome with Federica Sanguiolo, who is a good friend of ours. In Bulgaria, we published the situation quite well with Gala Petrova, but not only, as I said, for mainstream Bulgarians, right, but also for the Turks and for the Romani minority. So an ethnic-specific approach is very important, and you can see how heterogeneous the composition is. And it's quite important nowadays because recently, at the end of February, the European Medicines Agency made a ruling that so-called non-class 1 mutations could become eligible, and ECFS working group is working on assessing a list or preparing a list of which these mutations are. So if you sequence, you assure high quality targeted treatment to everybody. And all of a sudden, this could seem as an academic exercise, well, it's fine, mutation heterogeneity. All of a sudden, many of these could fall into this EMA regulation and could be eligible for modulators. Bosnia-Herzegovina, here it's quite difficult to get the cases, but we are still grateful to work either with, Duška and her team, and with some people local on the ground, like Ana Selimovic or Mesuda Hasanhodzic in Sarajevo. And you can see that, for instance, this duplication is quite common there. So it will be quite interesting if we also see it here in Albania, and it's not amenable to assays. Croatia, here I cannot say more, thanks to Duška and Dorian for what they have been doing, not only for Croatia, but also for the Kosovar patients they have. Hungary, very good collaboration with Debrecen, and Moldova with Svetlana Ščuka. Northern Macedonia, we have 2-decade-long collaboration with Diana Plaszewska-Karanfilska. Diana is fantastic, and she does her best even with limited resources. Serbia, the same with Daniela and Milan Rodic, and you can see that the heterogeneity increases. The same for Ukraine and Romania. So in the end, we found 28 novel alleles, and we are really pleased that 10 of them were submitted to as completely new to CFTR2. So we are adding the volume of knowledge worldwide, and having this broad panel. And this is a little bit older slide, but as you all know, it's not only the sweat test, but it's also the validated, and I stress that validated presence of known CFTR-causing mutations, which is part of the diagnostic assay. And in US, for instance, we have a list of 100 alleles. And again, now the game changer is the new EMA ruling, and we will have to see what comes out from the joint CFTR2, CFF, and ECFS working groups as to what the non-class 1 mutations are and what is their listing. So just very briefly, this is how it looked like before. For ivacaftor now, this is the double combination Teza-ivacaftor. This is the ETI for US. Then you have the French compassionate program, which we can leave for the sake of time to discussion. And we are now part, together with our colleagues from Brno, in a very interesting project which assesses good quality standards for compassionate use for all rare diseases. And it's very, very rewarding. And in fact, the French did a very good job in this regard. Then you have this additional panel, and then all of a sudden you have this ruling from the European Medicines Agency. So in the end, genetics was considered even by the pharma, even by Vertex, as a bygone thing. We have F508del, forget it. It's all done and dusted, but it's not the case. You really need to work worldwide. CF is not only a European disease. And in fact, just by chance, I want to tell you that most CF patients are nowadays born in India and Southeast Asia, even with the lower at-birth prevalence. And this is how the eligibility for modulator therapy looks worldwide. And I would say Western Balkans is somewhere, sorry that doesn't show, but somewhere here in the middle. CFTR2 and in the end. So just for the sake of time, so we need to bear in mind sequencing will be with us now more and more. It's a technology which is fully developed. It's getting less and less expensive, which is also great, although there are some monopolistic tendencies, and IVDR also complicates the issue. It helps to establish the diagnosis. It is a key precondition for newborn screening, which we see in our IRT DNA protocol, and I'm looking forward to the experience of newborn screening, which we'll have another talk. It adjusts current diagnostic algorithms, And of course, it's very important to assess the correlation between the genotype and the less severe or less frequency FTR variants. And in the end, I'm really grateful to Lutz for pushing the upcoming ECFS scheme in WHO Europe countries, which will enable us to continue once the donations from I would say, kind people in small companies will dry out, and once we go on a more standard basis. So don't hesitate to send us cases. It's very simple, and we will be happy to help as before. Thank you very much. And this is Malgorzata. She's the one who's behind that. She's a lovely lady and a very keen dog owner.
Thank you for this very comprehensive talk. I think it's a lot of aspects. Are there questions in the room about that? Yeah, I think there's one from Prague as well.
Good morning. Hi, Milan. Milan, so you mentioned the complex alleles. How we actually detect them? How you pick the patients to check if they are with complex alleles? Because this is not part of the classical genetic result. So on which grounds you actually select those patients and do the deeper analysis and find the complex alleles?
Pavel, very good point. It has several stages. First, the complex alleles were there even prior to the paper of Nicoletta Pedemonte, which showed up that some patients do not respond to ETI. I'll show you here. So we knew they were there, but we did not know that they are the ones who are responsible. So only after this Nicoletta Pedemonte paper came out, we said, hey, no, that's strange. So let's have a look either this way. Not to scare the patients and not to scare the patient community. Let's have a look, in retrospect, how many complex alleles we found. So Malgorzata went back and found, I think, 4 or 5 more cases in our CF registry, and we notified our clinicians, hey, have a look whether they are non-adherent, have a look whether they respond or not. But this situation, as I said, in the non-responsiveness situation, is only because it's a recessive disease if either there are 2 non-responsive complex alleles on each of the chromosomes, or the other allele is non-responsive, is essentially has no function, no residual function. So, for instance, we found it in a case which has 621+1 and the complex allele on the other side. We found it on one which has the CFTR delete 2,3 and on the other side. But if you have it more common, but we don't have it in our country, then you have 2 delta 508s complex alleles against one another, so the patient is non-responsive. So we did it, we looked at it the first way. Now we don't want to, because still it's a lot of unknown, so if we find a complex allele, we don't openly report it because it could mean that a patient will not become eligible for ETI, while we still don't know unless you do the sort of observational trial whether they respond or not. So only afterwards, and the clinician should be notified. We try to do that on an individual basis. If non-adherence and all these things can be ruled out, and still it doesn't work, the sweat test doesn't go down, then let's have a look and let's see what's going on. What we now see is, and then Malena is one of the forerunners, is that it's in fact non-responsiveness. It's either partial responsiveness or delayed responsiveness. And now in our cases, we work with the people at Erasmus because we see that if you do artificial intelligence-based analysis, Pavel, of MRI scans, you can see positive processes and the bronchial dilations are getting, but you don't see the sweat test. So sweat test is a great marker, but it's not the only one to assess response to therapy, because most of the cases who have this complex alleles are so-called non-responsive. Their nutritional status is going up, their stamina is going up. So if you look beyond the clinical trials and if you look beyond the sweat test alone, they are benefiting on ETI therapy, but not as expected based on the SPC label of a given drug. So it's again sort of an off-label therapy, and we need a more standardized approach how to look at it. I hope I didn't confuse it, but this is how it is, yes. Individually, carefully.
Okay, thank you very much. I think you will be here in the coffee break. So thank you very much.
Thank you.
Thank you. And you can ask. Unfortunately, the next speaker will not be available here, I think, to talk about the mutations in Albania, I think, Anita Barbameto. So we go directly to North Macedonia, to Professor Fustic, and to share her experience about the newborn screening in North Macedonia. The floor is yours.
Good afternoon, dear organizers, dear participants of the Southeast European CF Conference. Thank you for opportunity to present our results and experience of newborn screening for cystic fibrosis in Republic of North Macedonia, which has been implemented in our country for more than 6 years. This is for which? Oh, okay. Regarding newborn blood spot screening for cystic fibrosis, there is wide agreement on the benefit of newborn screening for CF with respect of clinical outcomes and health economies. That's why newborn screening is considered an essential component of the standards of care for cystic fibrosis. Early diagnosis through newborn screening and early appropriate preventive and curative care management of affected children in specialized cystic fibrosis center for the start of their life will enable the achievement of good nutritional status, prevention of chronic lung infection, first of all, chronic Pseudomonas aeruginosa infection, maintains a good lung function, and a healthy and active life of people with cystic fibrosis. Nowadays, in the era of CFTR modulator therapies, that correct the basic underlying molecular defect of the disease, early diagnosis with newborn screening will enable timely introduction of therapy in future. Newborn screening program for cystic fibrosis, as we can see in the map, newborn screening has been progressively expanding in Europe during the last 2-3 decades. At the end of last century, in 2000, newborn screening has been implemented only in a few areas and was more often research and regional project than an established national screening program, only in Austria, in Wales and North Ireland. Over time, more evidence in favor of benefits on newborn screening accumulated, and newborn screening and its practice progressively expanded in more and more countries in Europe and in the world with predominantly Caucasian population. And in 2019, with dark green are country with national screening programs, light green with regional screening, and orange are country under consideration for newborn screening for cystic fibrosis, and white countries with no plan for screening for cystic fibrosis. As you can see, in 2090, only Macedonia among Balkan countries have national screening program for cystic fibrosis. that cover entire newborn population. And this is the map for newborn screening program across Europe from 2022, published in Journal for Cystic Fibrosis in 2023. Again, dark green are national screening programs, light green are regional screening program covering entire country. Yellow are regional screening program not covering entire country, and orange-brown countries under consideration for starting newborn screening in future. And I hope some of these countries have already started newborn screening. Newborn screening for cystic fibrosis was introduced in the Republic of North Macedonia in April 2019, included in a national program for mother and children care of Ministry of Health. After 6 months pilot study in 2018, when 5 cases, when 5 children with cystic fibrosis were diagnosed for 6 months. A 2-step immunoreactive trypsinogen algorithm is performed, and then sweat test for confirmation or exclusion the diagnosis of cystic fibrosis when both ART values are over the cutoff. The first cutoff value is 70 and the second 50 nanogram per milliliter. The diagnosis of cystic fibrosis is confirmed in newborn screening positive case with sweat chloride concentration 16 and over millimole per liter. Infants screening positive with intermittent sweat test result with sweat chloride concentration between 30 and 59 millimole per liter are cases with inconclusive diagnosis. For them, the next step, the next procedure is CFTR gene mutation analysis, and certainly we do CFTR gene mutation analysis, and in cases with confirmed diagnosis with sweat test. If baby screening positive is under 3 kilo, then then the genetic diagnosis is made as first because his arm is too thin to perform sweat test. And this is the algorithm. As I said, first step, second step, and then sweat test in screening positive cases. Cases with positive and intermittent sweat test result are referred to CF unit for further evaluation, clinical evaluation, and follow-up, and certainly with for genetic testing, as I said, after signed informed consent from parents. In screening positive cases with sweat chloride concentration below 30 millimole per liter, the diagnosis of cystic fibrosis is ruled out, and we denote them as false screening positive. Since CFTR gene mutation analysis is not the second step using initial blood spot is not the second step in our protocol, as is in most European countries and in the world. We have limited number of patients with inconclusive diagnosis or cystic fibrosis screening positive inconclusive diagnosis, known as also as CFTR metabolic syndrome. And these are our results from newborn screening. As you can see, the number of newborn diagnoses with cystic fibrosis during this period varied per year. Among 112,192 screened newborn, the diagnosis of cystic fibrosis was made in 28 newborns, and 4 newborns were missed on screening. 3 of them were with meconium ileus, and it is well known that infants and newborns with meconium ileus and ileus usually have initial IRT value below the cutoff and are newborn screening negative. Therefore, all cases with meconium ileus should be considered as cystic fibrosis until proven otherwise. In recent years, we have good collaboration with our pediatric surgeons, and all cases with meconium ileus after a surgical treatment are referred to our center, so the diagnosis is made within the first 2-3 weeks after birth. One case with second IRT value below the cutoff was missed on screening. We believe that the reason is later age for second blood spot collection. The child was hospitalized in local hospital, and the staff, although informed, sent the second blood spot later, 7 or 8 weeks after birth instead of 3-4 weeks after birth. So we received negative screening result. Also, the child had cystic fibrosis. The diagnosis in this child was made at the age of 3 months, symptomatically, yet it was early diagnosis. So among these 112,192 screened newborn, the diagnosis of cystic fibrosis was made in 32 newborns. Newborn screening for cystic fibrosis showed that the incidence of cystic fibrosis in Macedonia is 1 to 3,500. North Macedonia is a multi-ethnic country. In newborn population, Macedonia of Slavic origin are in majority, contributing with 53%, 30% are Albanians, 7% are Gypsy, 5% Turks, and 5% other ethnicity. So among these 32 newly diagnosed children with cystic fibrosis, 20 were Albanian, we were ethnic Albanian, and 12 were Macedonian. The newborn screening for cystic fibrosis revealed a huge difference in disease incidence between the 2 largest newborn population in Macedonia. For Macedonian, 1 to 5,470 newborns, and for Albanian, 1 to 2,240. And all newly discovered cases with cystic fibrosis, in all of them, diagnosis was confirmed by determination of 2 CFTR mutation in trans. The most common CFTR mutation, F508, 8 deletion was found with an overall incidence of 67% in this group. Other more frequent mutation were G542X and N130T, and 2 additional mutations were found in 2 cases. 7 mutations were found in 1 CFTR allele, and the last 2 are newly discovered CFTR mutation. And this is genotype of CF patient, diagnosis on newborn screening, and the number of patients with same genotype. In conclusion, we can say that our Balkan region saw marked genetic heterogeneity for cystic fibrosis, attribute to a long history of population migration from Middle East and Europe. Newborn screening revealed a large difference in the incidence of the disease between the Macedonian and Albanian newborn neonatal population. Maybe the closeness of Albanian population over the century, including consanguineous marriages, contribute to greater incidence of pathological gene in this population. Our 6 years experience with newborn screening for cystic fibrosis give us promising results and objective hope for keeping patients in good health, good nutritional status, adequate control of pulmonary infection, and none of these newly diagnosed patients have chronic pseudomonas infection, and timely prevention of disease complication. And finally, there are objective prospects that this year, the start of modulatory therapy, Kaftrio in combination with Kalydeco, will be approved from the age of 6 or maybe even from the age of 2, which will allow patients with cystic fibrosis in our country to live healthy and productive life. Thank you for attention.
Yeah, thank you for your very informative talk, and also congratulations to the results and also to the good coverage, I think, on the slide. Are there any questions from the audience, I think?
Maybe if I can, Stoika, thank you. Really very nice results. You mentioned consanguinity in Albania, in Northern Macedonia. Do you have any official figures? Because that could explain the situation where some of the most common mutation, F508del, is so common. Do you know any figures on consanguinity? Are there any public health data on this?
We think that it is the reason for high incidence of pathological gene of this mutation, because there are more closeness and if there are some relatives, so I don't have exactly evidence, but we presume that it is the case.
It is, yes.
Okay.
Thank you very much. Then we come to the next talk, I think, from Kosovo, I think. Flora Ismail-Yaha. I think challenges in treating CF patients in Kosovo. I think you are impressed by the high prevalence and incidence, I think, in Albanian population, so there's a huge job to do.
Thank you very much. I do thank each of you individually that you found time and opportunity in your very busy agenda to come to Kosovo and give us a lot from your experience and support us in this joint combat that nobody should left behind. My lecture is not related too much to the direct treatment of the children, but related to our challenges as medical community on treating these patients. If you do require Kosovo, in Google you do find that Kosovo is the youngest state in Europe with the newest younger population in Europe, so this makes us responsible in order to deal with this diseases reflecting in pediatric ages. That is why we in the register for cystic fibrosis we have about 149 registered cases. Which are the challenges we do confront? Means human resources, limited human resources, inadequate access to proper treatment with insufficient infrastructure, and what maybe should be raised as a problem is awareness of medical community and population in general. Most of lecturers who were yesterday and day before yesterday and today speaks that cystic fibrosis is a disease which should be treated by a multidisciplinary team, which includes pulmonologist, gastroenterologist, physiotherapist, nutrition, nurse, very important, and social worker. We have a bit by everyone, but we don't have trained specialists who deals only with cystic fibrosis. So there are some moves recently. There are some individuals who are interested to deal with this activity, and they call it the knowledge on this disease more than what existed before, but as a team still is not properly functional. That is why this leaves consequences in treating CF children. I won't talk about treating because I just wanted to add that from every item we have it here in this slide, we need a support, we need need for increase, and we need to do a bit more for children and CF persons. When we speak about pediatrician clinic, that is a unit still not very well organized, but which functions with years, and as such provided to CF children treatment and follow-up. It is a unit of having 4 rooms with a single bedroom, but which yet doesn't meet conditions for long-term treatment and monitoring with cystic fibrosis. Also, intensive care unit needs periodic support of capacity building, considering infrastructure and human resources capacities. Awareness, little awareness and social support, it is another problematic in a small country, not well sustainable economy, because still there is a little awareness on CF, and as such we have disabilities on supporting families and who have persons with cystic fibrosis, and afterwards provision of information on disease management. Professor already mentioned that migration of population from poor economy countries to better economy countries played a role in this change. This reflected in Kosovo. In recent years, we had moves of families with children, and especially to Scandinavian countries and France. So I do believe that it's, of course, for the parent to seek better conditions and better support for his own children. I will speak on some options. I won't stick too much. I'm not saying establishment of CF unit, because that is already existing. Well, the case, not maybe well organized as a unit, but as someone who provided support and monitoring to CF children, but maybe higher support of this unit in meaning to be strengthened, and as such provide treatment opportunities and establish multidisciplinary team in the clinic. There is a deal, there is a relation, but it's not well established from people who will deal only respectively with this pathology. The other item, which is quite important, is what you have done. You've come here, you provided all your expertise, on which we are very grateful. It is ongoing education of medical staff and nurses as well, who makes or keeps the main burden for the treatment and provision of this workshop and allocation or sharing of your experiences along with us. The government should do more than us, maybe establishment of specific labs, microbiologic labs. I'm not talking about genetics. In none of the presentations, we didn't have our diagnosed genetic cases, even though, frankly, we have tried several times to publish, but we weren't successful. So I do think maybe we will establish a relation together and we will try to publish our cases. But fortunately, Ministry of Health provided us support for genetic diagnostic. So we've done a very important step on this, but there is a lot more to do to improve the conditions in regard to devices and supporting CF children. The awareness should be provided in ongoing basis, in meaning of health professionals, in meaning of maybe campaigns and community, because unfortunately in Kosovo there is a stigma on chronic diseases, specifically for CF. Fortunately, in recent times we have people who found courage and confronted and indicated that their children on themselves having a chronic disease, even a CF. But I do think we have still more to do about this issue. This is up to the government. We have present members of Ministry of Health here. That is why this is a call to them to support us even more in order for us to give our best for treatment of CF children. Another idea which might be maybe establishment of a fund which would be able to assist the families who do confront these issues, because as we do know, treatment of CF is quite expensive treatment, especially considering our economy in Kosovo. It's a high cost to the family and a high burden, economic burden for the families. In regard to the social support, that's something we don't have well organized. We have a Cystic Fibrosis Association. We have a Cystic Fibrosis Association which is quite active, and maybe fortunately their work that made us together with health professionals as well and increase the awareness of the population and health professionals, because at the end what mostly incites us for work is the parent who or the family member who has such a person in their family who needs our help. We have to improve information in meaning of fair nutrition and physical therapy, which sometimes in Kosovo is not well regulated. I'm saying there were multi-year experiences to do better, but unfortunately we are missing maybe the multidisciplinary team. Cooperation, international cooperation is what you've done. You've came here, provided us knowledge, assistance, maybe even opportunities for future cooperations, but maybe it's we have to have a move from a government maybe to construct a hospital in the region, maybe wherever we need to treat a person or a children to help us for this kind of treatment. Another problem in Kosovo is on adults with CF, because unfortunately we still don't have health professionals on adults which have started or would like to deal with this pathology, because we are still missing the connection with them. There is an opportunity maybe to make a national database, in meaning of afterwards that national database could make calls for having regular checkups, because this is missing in Kosovo, and unfortunately we don't have a correct data or calls to CF persons and their family members, in meaning that quite often we are relied on the desire and parents' support for the children, but not on finally we should call them in person to come and follow up these children, in meaning that to prevent infections and aggravated complications. The last one, health insurance fund, which should be realized. Still, we don't have the health insurance fund. So the government provides the support, but that's not sufficient for the treatment of such serious and expensive disease on cystic fibrosis. I will conclude with some beauty pictures of Kosovo. I do know all of you are here for work, and I do wish you next time have much more time and visit from Olpiana, constructed in the Roman Empire, and a lot of beauty other places which Kosovo provides, because except the youth, we fortunately have also some very beauty places. So thank you very much.
Yeah, thank you very much.
Po, faleminderit. Shpresoj që edhe konferenca jap shumë ndikim. Mendoj që kemi mjetet edukative, mendoj që kemi disa mundësi të mira në Shqipëri, ne kemi ofru mbështetje me bisedimit me qendrat e Europiane të Fibrosis Cystic, ndoshta mund të fillojmë të plotësojmë disa svrastira, dhe kemi projekti i binjakëzimit do të rrinë në mënyrë të vazhdueshme, dhe mendoj që vetëdijsimi
overcome the stigma, but there is also a question in the audience. That's good.
Okay, it's not a question. I just want to mention, to acknowledge you, to congratulate you and all your team. For me, it's a pleasure to be here. And yesterday, I visited your hospital. We met one of your patients and your dedicated nurses in the department. And I see that you are the example of how can be done the good with limited resources. So I want to congratulate you, and all your team, and thank you for all your organization, and I feel that I am honored to be here. Thank you.
Thank you. Thank you for being here.
Okay.
Maybe just very quick comment. Whatever in genetics, we are here. No problem.
Thank you.
Publications, test.
I already have your emails, so I will write to you. Thank you.
So we will come to the last presentation. Marlies from Brussels and from Utrecht. We're going to talk about, I think, a problem which is a little bit in between with coming with newborn screening. So newborn screening is one of the first parts, and then I think the inconclusive diagnosis.
Thank you, Lutz, for the introduction. Maybe I will explain the Brussels-Utrecht situation for the people who are confused. I am a pediatrician in training in Brussels, but I'm also doing a PhD in Utrecht. So that's the reason why. So thank you for having me today. I will talk you through the designation CRMS CF SPID. But before we start on CRMS CF SPID, it all starts with the newborn screening. So as you heard already today, over the years, many countries have adopted newborn screening. And on the right, you can see all the countries that by 2020 have adopted newborn screening. And yesterday, we also heard that in Kosovo, a lot of efforts are being made to implement newborn screening as well. So that's great, because we all know newborn screening is important for early detection. But there is also an unwanted side effect, because we are now identifying infants who are healthy with a positive newborn screening and a subsequent unclear diagnosis. In the US, we used to call these children CRMS, and it stands for CFTR-related metabolic syndrome. And the word syndrome might be a little bit confusing, because by definition, these children are healthy. And the word metabolic, it reflects the elevated IRT in the newborn screening, but that as well is maybe not right in this situation. So in Europe, we said this name might lead to over-medicalization, so we need another name for these children. So in Europe, they decided to call it cystic fibrosis screen-positive inconclusive diagnosis. And in 2016, some people said, we need to do a global harmonization process to get an international definition, and it was decided that we would call this CRMS CF-SPID. Now, what is the definition of this CF-SPID designation? It all are asymptomatic infants with a positive newborn screening and a normal sweat test, so below 30, with 2 CFTR variants, with at least one of which has unclear phenotypic consequences. Or an asymptomatic infant with a positive newborn screening and an intermediate sweat test with 1 or 0 CF-causing CFTR variants. Now, in 2020, the Neonatal Screening Working Group conducted a survey study to see how everything is going with the newborn screening in Europe, and they found that in 2019, 1,026 children with CF were diagnosed after newborn screening, and in that same year, 181 CF-SPID children were identified. So that gives us a CF to CF-SPID ratio from 6 to 1. But really, the frequency of CF-SPID is dependent on the algorithm that is being used. Because on the right, you can see that over different countries, different protocols are being used. And we know that when you use extended DNA analysis or extended gene analysis, it will increase the detection of CRMS CF-SPID if you do not combine it with the second biological tire. So to give you an example of this, in France, they use IRT DNA IRT algorithm, and they have a CF to CF-SPID ratio of 18 to 1. So they have 18 CF-SPID diagnoses for every, 18 CF diagnoses for every CF-SPID detection. In comparison to Poland, where they use IRT DNA extended gene analysis protocol, there they have a CF to CF-SPID ratio from 1.3 to 1. So that's a lot more of CF-SPID being detected. But what's the fuss in these children? Most of these children will remain healthy throughout their childhood life, but we know that they might be a little bit more at risk to develop CFTR-related problems later in life. So some of them might convert to CF, some of them might develop CFTR-related disorder, but most of them will remain healthy. So when should we move from the label CF-SPID to the diagnosis of CF? A change in sweat chloride concentration is the most frequent reason for a conversion, but also the reclassification due to new knowledge of a specific CFTR variant is a reason to do so. Also, sometimes pathogenic terms can indicate CF in children, and clinical symptoms are not always very reliable markers to change the diagnosis. When should we move from the CF-SPID label to healthy carriers? So it's the same as why we move to CF. If there's a normalization in sweat chloride concentration, or if we have a new knowledge about the CFTR variants, then we can change the diagnosis. When should we move to a CFTR-related disorder? To get into this, I would like to kind of remind everyone what it is. So it's a clinical condition with evidence of CFTR protein dysfunction that does not completely fulfill the diagnostic criteria for CF. It usually begins in late adolescence or in adulthood. It usually is monoorganic, but it's not exclusively, so sometimes 2 organs can be affected. And for example, disseminated bronchiectasis, chronic or acute recurrent pancreatitis, or male infertility due to congenital absence of the vas deferens are part of this. But the risk of infants with a CF-SPID label developing a CFTRD cannot yet be determined because we do not have enough data yet. So we know that these children are healthy, but they have an increased risk, so we have to follow them up. And in 2021, updated recommendations were published on how we should follow these children. And in this paper, you also find this table, which gives a very good overview. And I have made a summary for you. So the recommendations say that you should review these children at least annually until they have the age of 6 years old. Sweat tests may be undertaken annually if there is any concern about clinical progress or if the result at 2 years of age is intermediate. And if you have a positive conversion, so if the sweat test gets above 59, you should repeat the sweat test in order to confirm the CF diagnosis. They also say to check clinical relevance of CFTR variants at the CFTR2 website or the CFTR France website every year, as every year we know more about certain variants. They also say that there is no evidence to support routine respiratory cultures in infants that are well. So only if you have clinical concern you can do it. And it's the same for chest imaging. So there's no need to do it routinely, but if there's any concern you can. For the lung function, there's also no evidence to support the routine measurement of LCI, but if there's any clinical concern, you can. About genetic counseling, they say that you should always refer the parents if you have new knowledge about the CFTR variants, and of course, primary care physicians should receive at least annually a report. Now, what does this paper say on what we should do with these children after the year of 6 years? They give us 3 options. Or you can discharge from CF specialist care and you can say, okay, now you can be followed up in primary care. Or you can say, we discharge you from CF specialist care, but you will see the specialist when the child is adolescent, because then you can explain the child yourself what CF SPID label means. Or the third option, they say you could continue regular specialist review if you think this is necessary. But this all depends on the patients you have in front of you. Now, what is also very important in CF SPID, so CF SPID is a very gray zone. It causes a lot of stress, anxiety in parents, so it's important to really communicate well with these parents, to always say the same things, so mixed messages should really be avoided. And the communication of positive newborn screening results is not really a one-time thing, it's more a process from when the moment you give the parent the result until you have a definitive diagnosis. And what is also important is to, once the CF SPID baby grows up, becomes an adolescent, is to really explain to them as well what it means that they have been given the label CF SPID. For example, it's important to tell the youngster that when they have severe abdominal pain, for example, that they have an increased risk for having pancreatitis. So when they have severe abdominal pain, they should tell their doctor, hey, I once got the label CF SPID, please check my liver or my pancreas status. Also, it's important to tell them that there might be a chance that they have congenital bilateral absence of the vas deferens. So if they want to have children and they turn out to be infertile, then it's probably because of this, and it's easy to get offspring if we get them a little bit of help. So, to conclude, CRMS CF SPID is not a diagnosis, it is a designation for a pending diagnosis. They should be reviewed at least annually until the age of 6, and proper assessment should be done. The majority of these infants will remain healthy. They will not convert to a CF diagnosis in childhood, and advice on management should reflect this. Some of these children will revert to a CF diagnosis, so monitoring of these infants is also important. And some of them have the potential of developing a CFTR-RD later in life. And the last one is also a very important one. So we might need a special CRMS CF SPID registry, because then we will be able to better identify children who are at higher risk for developing CF later in life. So, this brings me to my final slide. I would like to thank Karen de Winter, who is my supervisor, but also Jurg Barben, who is the head of the neonatal screening working group, as they actually made this presentation and given me the permission to use this today. They have made this presentation to put up on the ECFS education platform. I don't think it's already up there, but I see Helen shake no, but it will be soon, I think, so please go check it out if you want to see it again.
Yeah, thank you very much for this excellent overview of a complex topic, I think. I would say, as a clinician from a country with low CF split, I would say we are screening for cystic fibrosis. We are not screening for all the potential parts. So the screening strategy, if you decide in Albania, should focus on the patients, I think, itself. So extended genotyping is easy, but the confusion might be overwhelm you, I think, in patients. So that's very important. And on the other side, we always have to be prepared for the late diagnosis, which is CAPE. So I think as we have seen from North Macedonia, I think there's one patient coming later with a false negative. In Germany, it's 5% of the patients who have a false negative screening. So screening is not false negative screening. So I think we should always be aware of the late patients, I think, or the patients born before newborn screening, which present at 10 years of age, so I think. So,
sure, very important. Thank you.
Any questions from the audience? I think without newborn screening, sometimes the experience is limited, but it will grow and it will be challenges on the way, and you have now a good connection to solutions.
Okay, thank you.
Okay, thank you. I think, thank you, then we close the session. I think they want to hand over something, but we have to shorten the break a little bit. But
yeah. Quickly, I just wanted to invite all the speakers of this session on the podium and the speakers of the next session. So we are all together to hand out some trophies as a memory and as a thank you symbol for your contribution and everything. And also information from the front desk. Please make sure to check out before 12, okay? Thank you. Can we invite all the speakers? Yes, please. Where is she? I would like all the speakers of the conference to be in the podium. Please, everyone. So all of you that had the presentation, please get on the podium so we make a joint picture. So whoever took the trophy, yes, of course. Dr. Shirma. All the speakers, please. Thank you. All the speakers. The ones that took trophies, I'm quite sure you know who took trophies. So. Dr. Stahl. Thank you. Hilde? Where is Hilde? I don't see her. Okay. Hilde? No, I don't see her.
tomorrow? Ah, tomorrow. This afternoon. Yeah.
Now, our sponsors from Emerald Hotel, Spresa, my right hand during all this time. So she was a big support and a big help. So really, really thank you. Mos harrojmë edhe mbështetësit tjerë. Kemi shumë sponsorë që na kanë mbështetur dhe na kanë ofruar ndihmën. Nuk po e di, apo e shoh Fllazat, lutem, Eja. Prej Mercury Hotel, darkën e parë dhe mbështetje shumë të mirë. Një mike shumë e mirë e jona dhe gjithashtu mbështetës financiar shumë i fuqishëm. Faleminderit shumë Fllaza. Përfaqësuesi nga kompania Beni, lutim të vjen në podium. Okej. Faleminderit shumë. Çdo gjë nuk do të ishte e mundur të arrihet pa mbështetjen logjistike, financiare dhe mbështetjen emocionale që keni ofruar për ne. Kështu që jemi shumë mirënjohës.
Okay, good morning, everybody. Could you maybe move forward and join us for the very last session of this wonderful conference? Please come forward, take a seat.
Let's continue with the multidisciplinary CF team session. A very interesting session is expected to be. I'm inviting Malena Cohen from Israel to present comprehensive care in CF, the role of the multidisciplinary team management.
Okay,
Please.
thank you very much. So I will do a brief introduction for this important session. And thank you again for inviting me. So more than 10 years ago, me and Eitan Kerem from Jerusalem, from my center, we described what we called the 10 golden rules of CF care. We described in these rules what are the most important things for follow-up of the patients and to treat the patients. It was published more than 10 years ago, before the new era of the modulators, but I think it's still very, very relevant for today. But if you can figure the number 9 and number 10, for me, are one of the most important things to follow patients. And I'm sure that you agree with me that center care with frequent, regular visits and strict adherence to all the above therapies are very, very relevant for today. So from the standards for care for people with cystic fibrosis that were published last year, what are the most important things for the CF team to follow up patients? So the CF care model is based on CF Center as outlined in the 2014 ECFS standards of care, and the first guidelines were described 20 years ago. And they said that the effectiveness of center-based care in improving survival and clinical outcomes for patients remain evident and relevant today. So now we have to reassess the traditional CF care model is essential, even when we think about the rising in life expectancy, the CFTR modulator benefits, and after the area of the post-COVID that affected all the world. Regardless of the care model, the multidisciplinary CF team remains essential. It's crucial for patients to be followed by multidisciplinary team. And so we can we can summarize the standards for care for people with CF. It's important the multidisciplinary team coordination with clinical discussions with all the multidisciplinary team, the comprehensive CF care to provide effective diagnosis, individual and personalized treatment for each patient, depending on the necessities of the patients. Data and registries is so important to be involved we know in the registries in order to improve the care of all the patients, and continuous learning. That's what we are together now and in each of the conferences. So what are the standards for care for people with CF? And we have to remember that the resources are very different and very complex in the different countries. Global collaboration is very, very important network between international patient organizations. The challenges in low resources and in low incidence regions in diagnosis, as we heard before, and in treatment of the patients, the equity in care. Less privileged regions should adopt best practices in order to give the patients the high quality CF care. Support and development, as the Twinning Project and as the CF Europe and the ECFS do every day. And patient-centered care, because we know that the patient is in the center. The multidisciplinary team participate, but in the center is the patient. And core CF care framework, despite changes, fundamental CF care principles remain essential for the good outcome of each of the patients. I want to show you tell you that we have in our center, in Hadassah Medical Center in Jerusalem, over a decade of experience in training CF teams worldwide. Our CF multidisciplinary team in Hadassah led international projects to develop and improve CF care all over the world, focused on training healthcare professionals and enhancing clinical practices, depending on the different regions. We supported the creation of sustainable care models for people with CF and collaborated with teams worldwide to share expertise and implement educational programs. And I want to show you some of our projects. This was a project led by Eitan Keren many years ago. We started in 2010. And the objective of this project was to create the first CF center in Gaza. So people from the multidisciplinary team from Gaza, with permissions, of course, they came to Israel for a term of 1 year, and we teach them, and we provided all our experience, and then finally they created the first CF center in Gaza. These are other of the projects that I was involved in South America. I helped people from Uruguay to create the first CF center in Uruguay, and now it's one of the better centers in this region. The first CF center in Panama, and these are some of our examples. But when we follow patients with CF, as I said, we have to concentrate the patients in a center of chronic diseases or a specific CF center. It's important to work with a multidisciplinary team. It's important to have consultants, because we know that, as Milan said, it's not a disease, it's a syndrome. It involves not just the lungs and the GI system, it involves all over the body in the patients. And it's important to have in the hospital the accessible tests for treating our patients. So the approach in CF treatment for the multidisciplinary team help in optimize care, decreases morbidity, increases survival, but increases also quality of life. What is quality of life? Quality of life is defined as the impact of disease and treatment on disability and daily functioning of the persons. And because the goal of treatments is to reduce adverse symptoms and make patients' daily functioning as comfortable as possible. This is the main reason, the main significance of quality of life. But there is a conflict between quality of care and quality of life in the patients. Burden of treatment versus daily living. They want to live. They don't want to spend all the day doing treatments and physiotherapy and taking inhalations and so on. Autonomy versus medical advice. Life-prolonging measures versus quality of death. Pediatric versus adult perspectives, because it's different. Who take care of the patients, of the pediatric patients, are the parents. And we heard yesterday about the transition to adulthood. Psychological and emotional toll, and it's important to individualize care as the solution. Empathy, flexibility, and individualized strategies. So this is the balance between medical care and personal well-being. It's not so simple. We know we deal with that problem every day, but it's important to give the balance between the two. This is my last slide because I have to leave soon. I want to thank you for allowing me to be part of this great community, one where country, resources, language, religion, and politics do not matter. What matters is doing our best for those in need. That's our mission. May God grant that people like those here multiply. And maybe peace in the world. And thank you very, very much.
Thank you, Malena. Have a nice flight. I'm inviting Fabio Maia from Italy to present the role of the physician in CF team.
Good morning, everybody, and thanks once more for the organizer for inviting me. I want to start over from this slide I showed you yesterday, because the standard of care demand us for a very holistic approach to the CF patients, which is great, but it's clear that it takes a village to be realized. It's just impossible for one professional only alone to make all of this. So this is why multidisciplinary team is fundamental. This was well known by Cystic Fibrosis Foundation, where in the 60s, a couple of families fostered the realization of the first cystic fibrosis center that is now an established reality around the world. This is just a model I took from the Cystic Fibrosis Foundation website. It is not true for everybody, for every country, or even for every center in the world. For example, in Italy, very few centers have as a program coordinator, but the psychologist in Italy is very often in the inner circle. But the model is true that the patient is at the center and a couple of professionals work around the patients, and some other specialists are called upon necessity. But the role of physician is changing regardless of modulators. We are in the era of technology, of information and knowledge, and advanced communication skills are required that does not come with our university degree. Sonia Graziano, who is our psychologist here, advised us that we cannot educate our patients like our parents did with us. So we really need some skills that are not always in our toolbox. We have a big variety of nutritional intervention, of pharmacological therapies on physiotherapy device. So one size does not fit all, and we need to be able to personalize. And technology is advancing both for communication with patients and families, and also as a tool to cure for them. Standard of care advocate for remote clinics, and so we need to stay on track. But CFTR modulator indeed changed even more the scenario, and I tried to summarize the change here with these schematics. of course, is just for fun. It's not entirely true, but new possibilities bring, of course, new challenges. So we need to be aware of the management of new chronicity. And what we knew before is not necessarily true. We were listening that not all patients required a hypercaloric diet anymore or salt supplementation. So it's a new era for a new disease. And longer life brings new issues, for example, as pregnancies. So the role of the physician in the CF team is to prescribe drugs, admit patients, prepare an individualized care plan, but this is not a one-man band show. Instead, I think of the CF team more as an orchestra, where you can share the responsibility of decision. You can have a different perspective on what is happening on a patient. I cannot count the time that I changed my mind on what was happening on a patient after discussing with a multidisciplinary team. And you can learn to have an effective communication and to bring that communication to the patient. Always with the patient at the center. Thank you.
Thank you very much. Thank you very much again. So I understood there's a change in the plans because of tight flight schedules. So now we are going to listen to Chris Smith, who's going to give us his insight of the role of the nutritionist in the CF team. Chris, the floor is yours.
Thanks very much, and thank you again to the organisers for inviting me. So I'm going to talk about the role of the nutritionist or the dietitian, and I've been listening very carefully over the last 3 days, and I appreciate that not everybody in the region has access to a dedicated dietitian or a dedicated nutritionist. But what I want to do is to present what I believe to be the 5 key roles of whoever is responsible for nutrition within the team, whether that's the dietitian or the physician or the nurse. So these 5 key roles that I believe that the dietitian or the nutritionist has are, number 1, to screen and identify those patients who most need prioritization for nutritional support. The second key role is to assess nutritional intake. The third key role is to adjust pancreatic enzymes to ensure the optimization of nutritional intake and get the very best from the intake. The fourth is to educate on the importance of nutrition and the role that it plays. And the fifth and final is to promote a high-quality diet, to look after not just the short-term but the long-term health of the people we look after with CF. So I'm going to take just sort of 1 or 2 minutes on each of these key priorities and give you the data that underpins them. So the first key role that we have is to screen our patients. And it's important that we screen based on BMI, which is the most common and quickly used assessment tool. But if we work in very busy clinics with very few numbers of the MDT team, or we don't have access to a full MDT team, then there can be other ways that we can efficiently and effectively screen which of our patients need our help the most. And there's been a variety of different nutrition screening tools that have been developed specific to CF that can be implemented in clinical practice. This first one here has been developed recently to identify high-risk infants, children between 0 to 2 years, who may require prioritization. And it helps to identify those that we need management. Now, I would suggest to you that all children under 2 with a diagnosis of CF should be considered to be high priority for nutritional support and nutritional management. But this screening tool can help. For older children, there was a screening tool developed in 2008 by an American colleague. This just takes 2 or 3 parameters and it allocates patients to either high, medium or low nutritional risk, very quickly identifying which children need priority. There's a second one developed also for children of this age group, developed in 2016. This uses around 10 different parameters, so it takes a little bit more time to input information, so it's not quite as efficient. but it's validated and useful to identify children in this age group. And in adult setting, there is no CF-specific screening tool that has been validated, but many centres use an example of this, the NRS. It's a European screening tool that again very quickly identifies patients and categorises them into low, medium or high risk. So screening tools can be a very efficient and effective way of identifying those patients. There are, of course, other tools we can use, such as this published in the JPGN, that allows the identification of the rate of weight gain, for example, for those children who have a low BMI or those children that have a high BMI, and you can identify it in the different age categories, the rate of weight gain and the rate of height gain, to clearly identify at an annual review whether a child is growing optimally or not. We can also use age as well, so nutritional risk is highest in infancy and in periods of rapid growth during pubertal growth spurts, and in adulthood during key times such as pregnancy and during post-lung transplant. And other high-risk factors include CFRD and bone health as well. So this is our first key role: screen patients who need our help the most and identify and prioritise them. The second key role we have is to assess nutritional intake. Now, this can be done in several ways. It can be done by doing a 24-hour recall. What did the person eat in the last 24 hours? We can use food frequency questionnaires that have been validated. We can use 3-day food diaries that families can complete before they come to clinic. Or we can use diversity scores as well. Some of these have their advantages, many of them have disadvantages, but they are very helpful and can be completed quickly and efficiently before clinic visits. It's not just important to look at calories and fat, it's also important to look at micronutrients as well. And the WHO specifies and separates type 1 and type 2 nutrients. Type 1 nutrients are nutrients where if you develop a deficiency, it has clinical symptoms, but there is no impact to the growth pathway. So for example, vitamin C, you develop scurvy, you have symptoms of scurvy, but it does not interfere with your growth potential. However, type 2 nutrients such as zinc often present without clinical symptoms, but can interrupt the growth pathway. So in the optimization of growth and health in people with cystic fibrosis, focus on type 2 nutrients within the nutritional assessment is really important. So that's the second key thing: assess calorie intake, assess fat intake, and nutrient intake. The third key role is to adjust, so adjusting pancreatic enzymes to optimize the nutritional intake. And many different formats can be used to support people to assess and get the correct dosage of creon. Many people use between 3 to 5 grams of dietary fat, requiring approximately 10,000 units of lipase. But it's also important that we have a role to assess acute symptoms that might be suggestive of malabsorption, and acute symptoms may be abdominal distension, and they may be steatorrhea, and also to identify chronic symptoms of poor dosing too, such as growth faltering or growth failure. So that's the third key role, to adjust pancreatic enzymes. The fourth key role is to educate. This is very important. We've already spoken, and you are all experts, so you're aware of the relationship between nutritional status and positive outcomes with life expectancy, hospitalizations, exacerbations, and quality of life. But communicating this message to our patients, to engage them on why nutrition is important, is really a key message. And whether it's using visual aids, such as the relationship between lung function and nutritional status, this is very important. And increasingly, we see work from an international collection of data from the CF community about the importance of good quality education coming from the CF team. Our patients look to us as sources of good quality information, so we need to acknowledge that and provide that. And then the fifth and final key role of the person allocated to nutrition is to promote high quality nutrition. The data that we see coming from Australia and from multi-centre studies across Europe has identified that the dietary intake of young people with cystic fibrosis is calorie-rich but nutrient-poor. Diversity is poor, fibre intake is poor, fruit and vegetable intake is poor. And this carries over to the work we're seeing that's now indicating the same pattern in our adults with cystic fibrosis. And of course, this makes sense. How we eat as children affects how we eat as adults. So there's an important role for all of us to promote not just a calorie-rich diet when it's required for the optimization of growth, but also to focus on the high-quality diet that will optimize and promote long-term health in the patient groups that we look after. So these are my 5 key roles for the person allocated to nutrition: to screen and prioritize high-risk patients, to assess nutritional intake looking at calories and micronutrients, to adjust pancreatic enzymes to optimize that nutritional intake, to educate our patients on why nutrition is so important, and to promote a high-quality diet for the optimization of good quality lifelong care. So I just wanted to add just 2 final things. The first is to say that, as I spoke about on the first day, the European Society's education project is dedicated to supporting these regions. And hopefully you've all had a chance to pick up your memory stick from outside, but I would encourage you all to pick up a leaflet and to access the education platform to continue to support your education once this conference has finished. And our emails are on that leaflet outside. If you have any issues accessing it, please contact Helen and myself and we will help you gain full access to that platform. And the final thing I wanted to say is I wanted to just thank the organisers for organising such a wonderful conference. I've had a really fantastic time. I've learned lots of things. I've met lots of new colleagues and I've made new friends. And for me, that's the sign of an excellent conference. So I wanted to thank you for that as well. Thank you very much.
Thank you, Chris, for your excellent talk and your encouraging words. Wish you a good flight back home, safe flights, and thanks for the flexibility. Then I would like to announce Marit van Oorschot from the Dutch CF Center, and she will elaborate a little bit more on the role of the CF nurse in the CF team. Are we with the right? Yes, we're there. That's a good change.
Yes, good afternoon. I would like to tell you something about the nurse practitioner, because we heard the last 3 days that it is very important if you are a CF center to work in a multidisciplinary team. And are there some nurses in the room here? Oh, okay. Okay, welcome. Nice to come here, and I will explain, because we have different nurses, and this is the role of the nurse practitioner. And what is a nurse practitioner? She is a registered nurse with a master degree in advanced clinical and trained, qualified to diagnose and treat illness, prescribe medication, and manage patient care. And we also have CF nurses. And a CF nurse is specialized in caring for cystic fibrosis patients, managing their medical care, and coordinating treatment and providing support. And what I hear the last few days from all of you and from you, that you do the lung function test, you do the sweat test, and you work on the ward in the hospital and for the daycare of all the children or adults. In our center in the UMC Utrecht, we have both. We have nurse practitioners and we have CF nurses. And in both hospitals, we have 3 nurse practitioners and 3 in both hospitals, and CF nurses working on the ward, and there are several. And what do I do? What is the role of the nurse practitioner? I am act as the primary point of contact for patients and their family from 8 in the morning till 5 in the afternoon. And after 5, the pediatrician will take the telephone and they will manage it at night. We also do the education about their conditions and treatments. We diagnose and we treat the illness. We can prescribe the medication. We order diagnostic tests. we design a treatment plan, and I always discuss the treatment plan after with one of the doctors, if they have the same plan or maybe another plan, so we can discuss that. We perform the medical treatment and we're providing education to the nurse students. So we do a lot of training in the schools. And the role of the CF nurse is, she is a little bit different, but she is also the guardians for the CF patient with all the ADL activities on the ward. She is instructing the nebulization and also the cleaning of the equipment, updating protocols, inhalations, instructions, support for the patients and their family, and also ensure that the hospital, if there is a patient in the hospital, that she is one of the key points that is okay with with the patient, and all the questions the patient has, she can answer. In our center, the CF nurse is not doing the lung function and she's not doing the sweat test. We have the laboratory who will do the sweat test for them. And if you look at one day of my life, when I'm in the hospital, what I told you, I have the telephone from 8 till 5. And we can call not only by the parents or the patients, but also the teachers from school, the doctors at their own house. So we can have sometimes, all the time, a phone call from somewhere. We are responding e-consults. They can give us an e-consult. Conducting the ward nurses daily, and we provide chronic consultation for the clinical care teams, the outpatient care, and the home care patients, and teachers, daycare centers. So everybody who wants to have or has a question about the patient, they can call us at the daytime. And also supervising and instructing patients during nebulization on the ward when there is a problem, or when the doctors on the ward have a problem, they call us. This is not my last slide, because this is my last slide, because I would also like to see, thank you for your attention and greetings from Utrecht. So visit Utrecht once. And then my last question, do you have any questions for me?
Thank you, Marit. Maybe one short question? Anyone raise your hand so we... Yes. Maybe do we have a mic for the lady in front? Yes, we have. Thank you.
Thank you for this excellent presentation. And I think what is important in this region to say, that the training of our nurses and the qualifications that they get, some of them do get the, let's say, high enough qualifications, but the main problem is that they are not recognized. These qualifications are not recognized by the system. So it is an administrative problem, and actually it all stands on the will of our dedicated personnel and nurses to do that. We really have highly dedicated persons and nurses, but no one has this qualification, so to say, how do you say, priznata? Acknowledged by everybody.
Thank you. I think that's a good remark, that it makes a difference maybe for how the care in a CF center is developed. And if you do have the devotion, as you're talking, explaining, but you also need the accreditation. I think that's what you're saying. Yeah, okay. Some nodding faces here. So that's wonderful if we can conclude with that good remark. Thank you for that. And thank you, Marit. And then for the next speaker, I'd like to have your attention for Erik Hulsbos. We have seen him presenting before. He's going to talk about the role of the physiotherapist in the CF team. There you are, Erik.
Thank you. And thank you
And for this opportunity to speak something about the role of the physical therapist in the CF team. And this is a known picture already, but you can see in this picture from the CF Foundation accredited centers what is required. Now, a program coordinator, a physician, but also a chest physical therapist or a respiratory therapist. In Holland, the physical therapist is also a chest physical therapist. He did some extra specialization in chest physical therapy, but also the nurse specialist, social worker, and dietitians. And recommended also research coordinator, also a physical therapist, more about cardiorespiratory fitness and health. Also a mental health coordinator and also a pharmacist is needed for a team. And also in this picture you can see it's always patient-centered care. So what I spoke yesterday in our workshop, and we sent to the organizing committee our slides, but also some inside information, reference values, but also the videos from different treatment options, but also diagnostic options. Because I think the physical therapist is very important to select, in consultation with the medical doctor, the most appropriate inhalation medication. Because the combination of inhalation medication and the most effective airway clearance technique, the combination make it effective for your mucus evacuation. Also to develop the most optimal treatment option for that patient. It's always patient-centered care, dus personalized care for optimal mucus clearance. But also train the patient and caregivers in optimal lung health. I think physical literacy is a topic now in our hospital, and there's also education, but also self-esteem, and also that the patient had some knowledge about how to get your lung so healthy as possible. Also, a tailored exercise program focusing on strength and cardiorespiratory fitness is I think, a main part of the role of the physical therapist. Address and assess also musculoskeletal problems and also posture problems to get the musculoskeletal system as healthy as possible. And also provide education. We do also a lot of research to get the best evidence practice for our patients, but also to provide education to other physical therapists in our area. And yeah, I think the last but not least, support the individual lifestyle is important. So I think when you work together in a multidisciplinary team, in a team, and all the team members, but most of the time the patient, together each patient achieves more when you're working together. So I think that's a lot of speakers are agree with it. And also multidisciplinary patient-centered team. The communication is very important, but also the most optimal care for patients in cystic fibrosis is, I think, the best when you're working together as a team. So thanks for your attention. No questions?
Any question? Thank you. I would like to invite Sonia Graziano from Italy to present the role of physiologist in CF team. Psychologist, sorry, excuse me.
Thank you. So welcome everybody in this second session dedicated to mental health. For those who were not able to attend the session yesterday, my name is Sonia Graziano. I'm a clinical psychologist and I work at the Bambino Gesù Children's Hospital in Rome. So psychologists are rapidly becoming key providers in the CF care teams. In the Hudson Guidance 5th edition, you can find a specific chapter on the role of a psychologist in the CF team. I'm going today to share some key points. First, most of the psychologists who work in CF are part of a multidisciplinary network of clinical and researcher affiliated with the Cystic Fibrosis Foundation or the European Cystic Fibrosis Society or American Cystic Fibrosis Foundation. In this picture, you can see some of the psychologists of the European Mental Health Working Group from the European Cystic Fibrosis Society. So, clinical psychologists in CF are experts in understanding the intersection of mental health and physical health, as well as motivating health and behavioral changes to improve mental health quality of life. They are familiar with the complexity of the disease and the complexity of managing the disease and able to assess relevant psychological symptoms and deliver psychological intervention. They are specialized in knowledge and experience for people with CF, and they facilitate the access to psychological treatment. So this is very important because it's important that people with CF can be in a relationship with a psychologist who knows the disease, so they don't need to explain the disease from the beginning. As we discussed yesterday, the TIDE study found that people with CF and their caregiver are at a higher risk for depression and anxiety, and these support a systemic screening and they use a family system approach to address mental health issue. So we know that family function and caregiver well-being are linked to the physical and the emotional health, and therefore supporting family members is critical, is crucial, is a crucial role of psychologists on the CF care team. Assistants tend to focus on anticipating additional stressors that may occur through childhood during periods of adjustment like adolescence, school, work-related transition, and during times of emerging distress. Systematic mental health screening is a routine now in most CF centers in the world, and this slide summarizes the model we use in our center, in many centers in Europe and in the US. Of course, after the diagnosis, which is always a stressful event, we start a supportive session with the parents, and we follow up them at each clinic visit. The psychologists work directly with the team, and this is very challenging time, and parents need both psychological support and personalized training to airway clearance and other treatment. Of course, at that time, the communication is with parents when children are pre-verbal, but slowly and gradually we start to work directly with the child. In addition, we conduct psychoeducational intervention, as we know that it's very important that the role the child gradually increase the knowledge of the disease to improve adherence. By starting conversation early, mental health check-ins become a routine part of the CF care in the clinic, and this is a preventive psychosocial support, and getting to know the family, it's very important. Establishing a relationship with them, it's very important and is a baseline for the future. And it's very important to open a dialogue about coping and mental health just from the beginning. In this model, when we integrate psychosocial care from the beginning, this helps to normalize the process of addressing emotional health and well-being and reduce the potential stigma. So we have many interventions that we can use as a psychologist in the CF treatment. You can see just some of them, like stress management, motivational interview, acceptance and commitment therapy, and cognitive behavioral therapy. Of course, you can also access to many resources. We built a lot of resource educational materials, and you can find these materials on the European Cystic Fibrosis Society session dedicated to mental health. And you can find a lot of PDF. We have English version, some Spanish version. We are updating also some Italian versions. I want to highlight this in this slide the importance of the therapeutic alliance that we build every day with our patient, and this is possible just with a multidisciplinary approach. For example, every day what we do as a psychologist in my center is to speak directly with the doctors, nutritionists, physiotherapists. We discuss the case, and sometimes we go together to discuss with the patient when there are a specific problem or specific challenges or barriers. In addition, we have a multidisciplinary case discussion, and where all the team members are involved. Another very important topic for the psychologist who works in the CF team is adherence. We know that CF is associated with a lot of stress linked with the treatment that they need to do every day. So our role is to help them and find strategy and work with the doctor, with the physiotherapist, and to find a good balance between what we ask and what is compatible with the quality of life of the patient. These are just some of the barriers we have every day with our patient. I am sure all of you know very well this barrier, and we work every day to help the patient to deal with these barriers. And here you can see some key tips for improving adherence. So it is very, very important to personalize and co-create treatment plan for people with CF. It's important to incorporate treatment into daily schedule and make them habit, because every time when I speak with my colleagues, we say we can ask 100% to the patient, because this is not quality of life. Maybe we have to find a balance, we have to find the strategy to help them to feel in their treatment. And of course, we have to promote support, disclose to friends. We know that disclosure is the most predictor of better quality of life and emotional well-being. And also, we, as a team, we work together to problem solve and fix the barriers. I'm at the end of the presentation, and I'm just to focus on some multiple approach that we can use with a very difficult time of life, which is a Sturm und Drang, as yesterday somebody told, phase, which is the adolescence phase. And it's very, very important in this age, build gradually the relationship directly with the patient. And we have some strategy that we can apply as a teamwork, not just a psychologist, because we are a team. And we need to work with them and do, for example, role play, ask the teen, for example, to identify the barriers and work together to find a way to deal with the barriers. We can focus on well-being, feelings and coping skills, strategies for stress management, and, for example, relaxation. Another thing is asking the question at the clinic with the CF team. So every time we try to ask the adolescents to have an active role in their care. So every time I say, if you want to ask somebody to the doctor, and you can write it down and come at the next visit, and we can ask together, we can speak together. Sometimes, for example, they are worried to speak, for example, about sexuality or other things. So, and very often we do this together with our MD. And so this, I hope I just gave you some idea of the work we do as a psychologist in the team. And very, very thank you to inviting me again to this conference. Thank you very much.
Thank you, Sonia, for your excellent speech. I would like to invite Jacqueline Nordvik, let's hope to spell it, okay? Then is her name, to take her speech about the role of the parent and the child with CF.
Thank you very much for your introduction, and to reassure you, this is the last presentation of 3 long but very interesting days. And I think I have a rather short presentation. Nevertheless, I think it's of importance what I want to share with you. This is about the role of the parents, and maybe some of the things that I will address will also apply to the patient when it's an adult, but it starts with the parents, of course. And we have seen in the last presentations how much education is needed, how much training is needed, how much we have to, as you as a CF team are explaining to the parents, training, communicate. I like the word communicating and the skills that you need to communicate about all those very different topics. So I think it's very important to realize that when parents are confronted with diagnosed with CF, that they really need to develop some extra and important skills. So what do? We don't have a physician at home. We do develop some medical skills at home. And when time is going on, we learn how to interpret what I call soft skills or soft signals, like, for example, a little bit of fever that you might want to. It worries you, and you think, what's wrong? Should I ask? Should I reach out or not? And maybe you also have to deal with the more serious incidents like exacerbations or lung bleedings. And that's a huge range of medical issues that you have as parents learn to deal with. And the other thing is, of course, when the diagnosis, it's running in your genes, so it's running into the family, and you have to explain your family about how this is inherited. What does it mean for genetic counseling? What does it mean for other family members? And that, can be done, of course, by genetic specialists and by the family doctor sometimes. But it's also the first questions are addressed to the parents. And then this very important CF nurse. We wish sometimes we could take her home with us, but nevertheless, the parents are the ones who have to guide the child through daily therapies. And it's just been described how difficult that can be. It can give mental issues. It does something with the way you're educating and supporting your child. But you also have to check the medication, the supplies. Do we have enough medication in our cupboards, in the kitchen somewhere stored for the next coming weeks? And we check with the pharmacist about the medication that's being prescribed. And that's, that needs coordination at home. And you do that with sometimes with the local pharmacist or with the pharmacist that's combined with the CF center. So it's already there, been told, been explained a lot. You have to digest a whole bunch of new health information. And altogether, I think it's very important that you try to do this extra, apart from raising a child with CF, it brings a lot extra to it. Now we jump to the dietitian. As Chris, I think it was yesterday that he pointed out very nicely that there's personal goals that you have to take in, like your nutritional plan is not necessarily something that goes for the whole group of children and adult patients. But redefining personal goals is also very important. Like now that we're in the era of demodulating therapies, we have to really carefully redefine those personal goals. And we do that, of course, together with a dietitian. But then you have to make it happen at home, which can cause stress and other mental health issues. And then, for the unfortunate patients that also have CF-related diabetes, they also have to manage that on a daily basis. And learning about healthy food and lifestyle is, of course, generally speaking, very important, but extremely important in these circumstances. So we had the psychologist giving a talk. Thank you for your insights right away. We would love to have you at home too, but it would be overcrowded, I think, with all those disciplines in one home. So as parents, you are also learning to observe not only about nutritional status, not only about the health issues, but also like behavior, like is your child thriving? Is it, well, especially now in the era of the modulating therapies, changing of behavior is an important topic nowadays, and how do you address that? And personally, I find it a little bit problematic that in this era you would explain parents that side effects of these therapies can be some behavior issues, for example. It can happen then that parents become too well, I was going to say obsessed, but that's maybe the wrong word, but they become very, very eager to follow up and see maybe problems that also could come from the growing, a 2-year-old or 3-year-old, a toddler acting like a teenager, giving these parents that kind of problems. And then we have the parental styles. I'm really, after being around for quite some years and spoke to many, many parents, parental styles differ. How do you educate people? Do you have talks at home together, sit down and see what is important in the upbringing of your children, and now that this child has cystic fibrosis, what does it mean to you? And are there any differences in how we both want to address the different topics? And coping mechanisms also might differ between the parents, like hearing about the diagnosis, hearing it first out of hand. One reaction might be looking out of the window and thinking, my God, how am I going to cope with this? And another reaction might be, I want to hug someone, I want to hold someone, I want to talk about it. And these are reactions that are and if you don't understand each other, and if you don't give room to those differences, you might be starting quarreling or not understanding each other, which is, well, challenging, I think. Compliance, it's already mentioned, so I won't dive into that anymore. And of course, we have the hopefully healthy siblings at home. And I think we all know about the problem that how we might try the best we can to give equal attention to each and every child with CF or without CF. But the fact that you're sitting down with this one child, helping it with inhalation, reminding it, take your medication, even those simple lines of communication can mean something to the other siblings. And I think we need some more research in how to divide your attention in a way that, 20 years later, the siblings are not looking back at it like, I felt a little forgotten, because and I think for a CF team, maybe it's a good idea to also have the siblings on board from time to time. And then the feelings of guilt. I just wanted to address that because something is genetically given to your children, and some parents really feel guilty about that. So that's a couple of psychologists in the home, I think, in the household. While this is all going on in the household, in the family, the parents and the children involved, it's also quite new for most parents that they have to adapt to a new system. And of course, this system is seen as very, very helpful because, everything is that you experience over there is an answer to problems that you have. But we also should consider the fact that the team is around the family, so to speak, and that's a very nice way of presenting it. Yet, it can be a little bit, can I say that, overwhelming. I did quite a lot of interviews with parents that, for example, told me, I feel no longer that I'm in charge, so to speak. Who is responsible for what? Some, medical things are prescribed to my child, but who is now in charge? And should I ask, for example, permission when going to a certain country for vacation? Or should I ask for permission when I want to celebrate a birthday in a certain way? So I think it's very important that in connecting with healthcare, the family has to work really hard, but maybe when we have those official description of how a CF team is organized, maybe the parents should have an official part in that too, so that we make that connection also official in cooperation and helping each other. I think this is one of the last slides that, talking about this, thinking about this topic, I wanted to address, the first thing is that I did some scientific research on how parents and patients perceive the quality of care in the Netherlands. And there was a whole lot to talk about that came out of that research, but the key message I wanted to deliver here is that for parents and patients, communication is key. That's what they, if communication is running smoothly, then people feel this, I feel helped, I feel being seen, we have a connection, so communication is key. Well, because of all the disciplines that we have at home, as I just said, and I even forgot to mention the microbiologist, because hygiene is also a topic, so we have the microbiologist at home. We, as a patient organization, we decided about 10, 12 years ago to develop a so-called coaching program. And this is seen as additional to all the information that's coming and the help that's coming from the CF team. It's, of course, voluntarily. People can register for this coaching program anonymously, and we do pay for it, so it's not necessary to go to any health insurance company to have it covered. We do that, and these coaches are, there's the word again, registered and acknowledged, and they do know a lot about cystic fibrosis. And so we make this offer for the parents, and also later on we decided to open this program also for adult patients. Okay, many thanks, and like the other people said, it's been wonderful to catch up with each other, so thank you for being nice to each other, and lots of success.
Jacqueline, for your interesting presentation, how challenging is to raise a child with CF in a multi-aspect, multi-dimensional aspect. It's very difficult, but thank you very much for your presentation.
I think then the floor is now for Hilde and her team, may I say. So you are going to guide us through the closing ceremony as it is in your program. The floor is yours. You want to be here?
Katarina, please join. Please.
So maybe while people are coming forward, I can start. For those who were here at the very start of the conference, you might remember that I said it takes two sides to build a bridge, and we build many bridges in this twinning project during conferences like this. So I should find another way of putting this. Maybe it's a platform, maybe it's a roundabout. And to make that stable, you don't only need two sides, but you need a lot of pillars. One pillar is you, the audience, who were here to learn, to network, to connect, and that is crucial. That is why we do it. Thank you for being here. Another pillar is our speakers, the experts being here to share, also to learn and to connect, I'm sure, but to build the program together with us. Thank you for sharing and for being here. But then there is no conference if there is not an organizing team. And these people are so important. That are the people here behind me. I didn't do anything. These are the stars. Thank you for all the hard work. Thank you for making this happen. I think the CF community is grateful to you. We had you here, we had the people online. We had so many interesting and important moments in the past 3 days. And we're looking forward to continue to build roundabouts and improve the care of people with CF and to strengthen the CF community. I wish you all a very good flight home, a good rest of the Sunday, but I also want to give the floor to the local organizers, Atoyen and Vlora, who did a lot of work here as well. So please.
Thank you so much, Hilde, for all these wonderful words. It was quite a journey, to be honest, and in the beginning we didn't believe a little bit. We had our doubts if it's going to go well or not, but I think all the hard work and all the commitment from this team that stands behind and support and expertise on all this helped to achieve all this and to be here at this moment with the closing remarks in front of you. So without adding any more, I thank you from the bottom of my heart for all the lectures, all the speakers, all the parents and patients that came and enriched our event with your presence. We are really grateful, and we hope to see you again in the next future, and we hope that this is just a building stone, the first step towards building a better future for our patients. So thank you everyone.
Okay, so Laura talked about all of you, but I just want to say a big thank to the doctors who helped us this week. So I want to be very thankful to them because they made a really good job in in a more technical part in our job, but they helped us a lot. And so thank you very much to all doctors who were behind us all this last week.
This is something extra. I don't like to have speeches or presentations, but I like to offer space to people who like to present. So it was so nice and very special half year by organizing this conference in this region. And it was a beautiful experience for me. And now, after these 3 days, I am full of emotions to meet all of these nice, open-hearted people who came to this place. And thank you to all speakers who came here in this maybe not usual country we visit. And I have to say thank you that you reacted on my emails, because I never met you. Many of you, I didn't know you, didn't know me, but you were so, how to say, supportive and enthusiastic, and have also good ideas and support the creating this beautiful agenda. And thank you to our parents and doctors and healthcare professionals from around countries and from Balkan countries who are here. And I hope that this will starting point for you, how you will continue this work in the future and find your way how to build the community and how to change your situation and how to improve the lives of CF families. And involve, as I love the presentation of Jacqueline on the end, she offered this presentation on the end, and it's true that we are all in one, and the parents have to be the part of the team. Thank you very much, and have a nice trip home.
Hello. I wasn't expecting this to be here now, but yes, as our colleagues mentioned before, we thank you very much to everybody, to the speakers, to the organizing team, to the technical team, to the translators, to everybody, and especially to you, because you stayed here with us until the end with 3 intensive and very informative days. And actually, the conclusion, and let's say a message, is that together and being here, being united, and exchanges informations, asking questions, we become stronger in order to fight, in the end, CF and to help the patients. And therefore, we thank everybody, from speakers to all the participants. And yes, indeed, we hope we will see you in next conferences. So thank you again.
So she's my wife. She said everything like at home usually. So I'm more a technical guy. I want a big applause for those guys there. 24/7, they've been a really helpful guys. Thank you. And thank you, CF Europe, for according us your trust once again. Thank you.
Thank you, everyone. I just want one more minute because I was really excited and emotional that this day is over, so to say, but I want to mention my supportive team that they mentioned. First of all, Afrodita, my right hand, then the girls, Arieta, Filayeta, Yehona, and Blinera, bravo. Blinera and Dieta for reading my mind. I didn't have to tell anything. They were just reading my mind and helping out with every detail. So big applause to each and every one of you. So now I want to invite all of you here in the podium so we take a joint picture together and then we can go to dinner, to lunch. I'm really tired. We can go to lunch and we consider this conference closed. See you next conferences. Thank you, guys.